Again, this is Todd Blickenstaff, President of the AAII Portland chapter, Portland, Oregon chapter, and also the Income Cash Flow SIG group meeting that we're having today, Thursday, November 21st. And I think that we're going to go ahead and start up here in the interest of everyone's time. And our meeting format's going to be a little different today. Normally we have Gilbert Ho also on the call providing his economic and market overview. But Gilbert can't join us today, and actually we need the time because this is a very complex subject. So we're going to be focusing really entirely today on the subject of Medicare. And but Gilbert will be back next on our next call. I know we have quite a few people that enjoy hearing that portion of the meeting. So Gilbert will be back for our next meeting. I want to remind everyone, if you do have questions, please enter them in the Q&A section, not the chat section, but the Q&A section. And that way I'll be able to monitor the questions as we go along. And we'll look, and there should be plenty of time for our presenter, William Gregg, to respond to those questions at some point in the presentation. So. And what I'm going to do at this point, and we do these meetings on normally the third Thursday of each month, including November, and we'll be sending out an email for the next meeting that we'll be doing. And we'll check to see if we're going to be doing a meeting in December since we're going in the midst of the holidays at that point, but we'll communicate on that clearly and give everyone plenty of notice for our next scheduled meeting. And we've got a variety of topics that we're going to be covering over the next year in the income and cash flow SIG group meeting, so we're excited about that. At this point in time, this is, and again, the topic of this meeting is Medicare. I think ABC is making the optimal choices during the annual enrollment season, which we're right in the middle of now. And our presenter today is William Gregg. And William has a varied career. I've known him for multiple years. And after an initial career in banking, William pivoted to a career as a successful intellectual property entrepreneur. He's currently self-employed as a product developer, having licensed over 20 different products to companies in several different industries and market channels, both domestically and internationally. And William is a very analytical guy, and he's studying health. He studied healthcare and Medicare issues kind of as a side interest to his day job, but it's a passion project, and he really knows his stuff on that. So we're very excited to have him as a presenter, and he's accumulated financial expertise regarding both the medical and pharmaceutical businesses. So at this point in time, what I'd like to do is turn the microphone over to William, and so he can initiate the presentation. And again, reminding everyone to please, if they have any questions, to enter them in the Q&A box there, and we will get to them either during or following William's presentation. So, William, at this point, I'd say, please take it away.
Okay, thanks, Todd. Hello, everyone. Okay, I'll preface it by saying I'm not a broker. I'm just a person that is kind of acting as an independent financial counselor. I try to bring this subject up having no biases. The subject of Medicare is very confusing, very complicated, changing all the time. I'm learning new stuff all the time. You're basically being asked when you go on Medicare to do something you've never had to do. You've always had an employee benefits manager for most people, and now you're being asked to be your own employee benefits manager. I won't talk too much about onboarding, getting on to Medicare, because there's just so many different things that go into place on when you first go on, and I'll just say that about half the people get on Medicare at 65 because they are no longer working or their spouse isn't working, and they have an open enrollment period, an initial enrollment period that they can get on at 65. And you also need to do that if your employer has less than 20 employees. And some people, half the people will get it after 65. And that's if you're working for somebody after 65 and you have more than 20 employees. If you have an HSA plan, don't do Medicare A or B if you do want to use that plan. If you don't have an HSA, just sign up for Medicare A only. Most of what I say applies to Oregon, but usually that kind of goes for just about any state. And I won't be talking much about Oregon Medicare savings plans or federal extra help because it doesn't probably apply to this group too much. So John, if you can go to the second page. Okay, I'm just first going to talk about traditional Medicare, also known as original Medicare. That's when you're signing up with the government, and it's called Medicare A and B. A is for hospital care, B is for medical care. And I'm going to try to show why this, as good as it is still not enough. So that second topic will be the addition of a supplement plan as an option. Third one would be replacing it all with a Medicare Advantage plan, also known as a C plan, or a Medicare replacement plan. And then I'll compare the two options, talk a little bit about Part D plans, both standalone and embedded, and a little bit about brokers, should you be using them, and which ones you should use. Okay, John, next slide. So I'll just talk about just Medicare A and B only. This is without a supplement or changing it all to an Advantage plan. About 3 million people do this and do this only. Out of the 66, 67 million people on Medicare, about 3 million people do only this. This is when you're signing up with Medicare only, both A and B, you're facing a situation where you have no network, which is a good thing. You can go to anybody. You don't need referrals. Medicare Part A, which is the hospital part, is free for most people, as long as you have 40 quarters of work. Medicare.
William, can I stop you with a question there? When you said you can go and see any doctor, but those have to be doctors that are accepting additional Medicare payments or patients, correct?
Yeah, it's first of all, that's about 95% of doctors and all hospitals accept Medicare, just having Medicare A and B. Some doctors that do accept Medicare can choose to say, oh, I'm filled up, I don't want any more. But
Right.
generally you get to see you're not subject to a network at all. You can go to anybody you want as long as they have an open spot. For Medicare Part B, which is the medical part, almost everyone pays a monthly amount, which is about 93% pay this figure. It's for 2025, it's going to go up to $185 a month. Most everybody pays that, although 7% of the people that have higher incomes will have to pay more every year. The 185 a month covers all the costs, but it leaves you with 6 gaps, which we'll go over.
If you pay more, that's called IRMA, right? That falls under the IRMA category.
Yeah, I'll go with that.
Okay,
right.
great. Sorry.
And for 2024, if your adjusted income is more than $103,000 2 years back, which is about 7% of the people, or $206,000 if married filing jointly, the Part B payment will go to $244.60 for singles. I just put that one down for singles. and it has 4 more brackets. So if you're the maximum bracket, which is over 750,000, is you're going to be paying for Part B, for the medical part, you'd be paying $594 for singles. A similar bracket system exists for the drug plans, which start out at $1,270 if you earn more than 103,000 2 years back, and goes as high up as $81. If you have that income, but then you find that after that income 2 years back that your income has been affected and you're making less money, there's several appeal processes using a Form 7 SS44 that you can appeal, saying, hey, I just don't make as much money as I did 2 years ago. And you have a pretty good chance of lowering that IRMA payment, and that's called the income related monthly adjustment amount. And then I wanted to say on the side here that, how valuable A and B is, even though it has all these holes in it. For people that have less than 30 quarters of work, they could get Part A, the hospital part, but it would cost them $505. So everybody that has the 40 quarters gets it for free every month. And if you didn't work at all, your B premium is still going to be just $185. Spouses do qualify if they didn't work under certain rules. Next page is A and B by itself covers preventive services, hospice, and limited home health care after a hospital stay. But it leaves you with 6 gaps, 3 on the hospital side, 3 on the medical side. I show those gaps on this page. On the left is the hospital gaps. If you just have A and B only, you'll be susceptible to paying 16 in 2025 for the first 60 day. For the first 60 days, you'll be paying a co-pay of $1,676 for each visit. And after you leave, the visit goes for another 60 days. So you can see if you go in 2 or 3 times that year, 60 days apart after you leave the hospital, you're going to have 3 different co-pays. If you then leave the hospital and go into a skilled nursing facility, for the first 61 to 90 days is $419 a day. 91 to 150 days is $838 a day. These are lifetime reserve days, those last 60 days. You use them up and you don't get them back. Okay. Well, that was actually still hospital stays, longer hospital stays. Skilled nursing is the first 20 days is $0. After that is $209.50 a day. And you qualify for that after you've been in the hospital for 72 hours. On the B side, for your medical part, your first gap is the Part B deductible of $257 next year. It covers basically both A and B, because when you're in the hospital, you're still having doctors call on you. So that's that gap. And then you have co-insurance. A and B will pay 80%, but you'll be subject to 20% for everything else. Your docs, hospitalist, labs, tests, equipment, home health care, the huge categories of chemotherapy, your Part B drugs, therapeutic radiology, which is high-end X-rays, and you'll have no max. You're paying forever It's a huge liability potential. The last one is excess charges. Doesn't happen much, but about 5% of the time, docs can charge 15% extra. So while on A and B, I'm if on the next page, I'm basically saying that I feel that it's just too much risk. You're just insuring too much. You're self-insuring too much, and you have too many gaps, too much liability. And so even though 3 million people stop there and they just carry A and B, the better option is either to get an added supplement, also called a Medigap policy. It's sold by private insurance companies. Alternatively, there is the Medicare Advantage route, also called a replacement policy or a Part C plan. People in general, about 30 million people do supplements, 30 million people do Advantage plans. And then I'll go over on the next page the pluses and minuses of each, and then a comparison of the two. First step is supplement plans. We're going to try to fill as many of those gaps as possible on both hospital and medical side. You're staying with Medicare if you have a supplement. It's just that you're adding a supplement to cover everything or most things that Medicare didn't cover, what I just discussed, all those holes, all those gaps. It's very easy to get a supplement when you're first on Medicare. You have guaranteed issue rights. You have a one-time chance to get on. At 65, there's an open enrollment window. Starts the first month you have Medicare Part B, and it goes for 6 months. If you start Medicare Part B after age 65 because you continue to work, but now you're going to go on Part B, you also have 6 months to buy a supplement. You're also, once you have a supplement, you can switch, if you want, to other plans, other companies. Generally, these are plans that are the same or lower than what you've signed up for. You can't go higher without underwriting, but you can go across or down. Obviously,
William, I have a couple questions in the Q&A section that might be appropriate for you to try to answer now,
okay.
if I can present them. One of them says, is there a penalty if one doesn't initially sign up for Medicare during the sign-up window that brackets the age 65 mandatory sign-up window? I've heard this penalty will assessed annually for the rest of one's life if you try to sign up after that grace period. I'm adding some clarification myself to this
Yes.
question that was submitted. Could you?
Well, first of all, most people are going on Medicare at 65. Some people can go on later on at 67 or 70, whenever they stop working. For somebody that's working for more than an employer that has more than 20 people, they can continue working. But when they are first eligible to go on it, they have to go on it, and they have to sign up for Part B and start paying the $185 a month. If they don't, yes, there is a penalty for Part B if they don't sign up. It's an added penalty every month, and if you sign up later, you can do that, but the penalty that you were on the months that you didn't sign up is going to follow you the rest of your life.
So you get that. So you have to sign up for Medicare Part B once you reach age 65, regardless of whether you're using that plan. In other words, you might still be working and you're on a health insurance policy through your employer, but you're still paying for Medicare in addition to that. Is that
If you're
correct?
on a creditable plan with your employer that has over 20 employees, you can continue to be on that plan. But as soon as you quit, you'll have an open enrollment time
Oh, okay.
to then sign up for Part B. And you have to do that within, 3 months it's basically you kind of sign up 3 months before, so you have a little bit of a grace period on the other side. Otherwise, you'll pay a penalty if you sign up later. And I've seen people do this, and it's not a small penalty either. And sometimes I think I've heard it's like 10% or something like this. And also, if you don't sign up for a Part D drug, for the drug part, especially if you're on a supplement plan that has a standalone Part D plan, you'll face a monthly penalty there also. It's not as large, it's like 1%, but it follows you the rest of your life. So generally sign up when you're supposed to and don't let it lag.
But I think if you what you did say though is if I'm an employer and I'm past 65. Let's say for example I'm 68 years old hypothetically, and I'm working for an employer, and they have a health care plan that I can stay on presumably as long as I'm employed with that same employer. And as you mentioned, employers that have more than 20 employees. So I don't have to sign up for Medicare Part B unless I leave that employer and I'm no longer on that plan. Is that correct?
Or unless you can have a better plan by going on Medicare than what the employer provides or what he's paying for. So you
Okay,
can't
right. So you have that choice, and it's worth making that comparison. That's a good point. I can tell you from personal experience, because I had a post-retirement medical plan that I was on after leaving my employer, and that was several years before I turned 65. But they basically the employer they kicked me off that plan as soon as I was Medicare eligible. They wouldn't have done that, I think, if I were still working for the firm. But this particular firm made the decision, we're not carrying you on our Medicare plan any longer if you're not still actively an employee. You
Right.
can't be a retiree and stay on their plan. I don't know if that's a rule or if that's just a preference that this particular employer made. That happened to me, so it's important to differentiate and be in close contact with your HR department if you have one for whoever you're working for to make sure you understand what their priorities are. And anyway, I thought I would point that out. Go ahead, William.
Right. And so no matter what you do, if you take a supplement or not, you're still always going to be paying the Part B premium. Hopefully not any penalties because you got it on time. You'll never pay. Most people will never pay for A. It comes free. Basically, what the supplements are doing is it's taking all those open holes that I mentioned in the last slide, and it transfers the risk of whatever Medicare and A and B doesn't cover. It transfers it to a private insurance company. Basically, it's picking up all those deductibles and the 20% of the medical that the Medicare doesn't pay. And again, you can go to any provider that takes Medicare, no networks. It's an open access system. You don't need referrals to specialists. And you'll pay upfront premium every month for it. It's a pay upfront policy. It's for lifetime. It's as long as you pay your premium, you continue on it. You don't have to re-look at it every year. It just stays with you. They can't cancel you. You can take it everywhere you want to go. It's portable. It's very quality insurance. Prices do vary though by state and by company, and I'll show you a slide of that in a minute. And there's also people that smoke pay a little higher rates for supplements. People that are men pay a little higher than women. Obviously, with a supplement, you still have to get a Part D drug plan in most cases. You'll have many to pick from. There's a few cases where people don't have to get it if they have credible drug coverage through other means, which I'll mention in a second. But
Could I present one more question here at this point, William? And I don't know if you're going to talk about HSA plans in any more detail later, but one attendee asked, said, I'm currently on an HSA plan at work. I believe I have to be out of the HSA plan for 80 days, 80, before I can join Medicare. is this correct? And also, why does the government make such rules? If that's, if you can answer part B, I don't know. Or, excuse me, part B of this question. So,
That one's a little over my head. I just know that if you continue to work and you're making contributions to your HSA, you don't want to sign up for A or B. Um, and if you don't have an HSA, you should just sign up for A only. That's kind of what I can say. These are getting into the weeds and stuff that I don't know this 80-day rule.
right. And it may vary in the case, my family, my spouse is not on Medicare, I am. And so we were able to do an HSA funded in her name. And so we were still able to do that, and we'll be able to do that, I think, for one more year until she turns 65 in our specific case. So.
Okay.
One other thing I wanted to say, I know David Reynolds submitted a question later, and the question disappeared. I may have done that by accident. David, if you still have a question to ask, please resubmit it. But and go from there. But anyway, go ahead, William.
Okay, next page. Continuing on supplement plans. Can you switch it to the next page, John? Okay. One of the good things about supplement plans is that, and this is a key point, no pre-authorizations are needed except for cosmetic procedures, which are usually not allowed, and also applying for mobility devices. Other than that, you don't have the problem of having to have your doctor or your hospital check with your insurance company to see if they'll cover it. It's one of the big benefits of having a supplement. If your doctor wants to do something, he gets to do it. No additional approval is required. You also don't have a MOOP with a supplement, which is you don't have a maximum out of pocket to deal with like you do with an Advantage plan. The bill gets sent to Medicare, who then sends it to your supplemental private company, and you usually get a statement with zero owing, depending upon which plan you got. And we'll talk about two plans here, the most common ones in a minute. It's best to get right when you turn 65 or when you first go on Part B, if you're getting it after 65. It's in an open enrollment period. You have nothing, nobody will ask you any questions. Supplementary plans also cover foreign emergency care while you're overseas, but only for the first 60 days of your trip. It has a $250 deductible. You'll pay 20% coinsurance after that, and with a $50,000 lifetime limit for that particular plan. I asked one time, what if you switch companies and switch plans and go with another company? You get another lifetime limit, I heard, what they told me. Also, SUPs will give you an additional 365 days in a hospital setting beyond the 150 days of Medicare A and B, and it's free. It's just concluded in with the SUP, so it's another huge reason to have a supplement, I guess. All right, the negatives of supplement plans. The obvious one is it's going to be an extra premium you're paying up front, basically, and it goes up every year. After several years, the premium can go up pretty high. These plans do not have perks. All those ones you hear about that the Advantage plans are offering, it's not going to have an included drug plan. You'll have to buy that separately. It won't have gym, vision, hearing, dental, extra benefits of any kind, any dentistry things. That's supplements don't have that. There's no overseas non-emergency coverage. All Medicare doesn't, no matter what you do, does not cover custodial care, cosmetic surgeries, massage, or at least with supplements, they don't cover routine physicals. An Advantage plan might throw that in, but none of Medicare in general does not does not have any of these covered. And like I said before, if the docs are full up, even if they take Medicare, they don't have to take you. Or if they've just decided not to take any Medicare, they just have opted out. If you have an HSA, you can't use it to pay supplementary premiums. If you don't, and here's a big one, if you don't buy it and you just get an Advantage plan and later want to change to a supplement, and you're outside the windows, like the initial window I was talking about, you will have to medically qualify to get it, except in New York, Connecticut, Vermont, Maine, and Massachusetts. For instance, New York has guaranteed issue rights. Oregon does not. And that means you can switch back and forth between Advantage and supplements any way you want, anytime you want. The negative to that is that I looked up the rates in New York for people that have that privilege to do that, and the rates are skyrocketed just because they do have that issue. So just because they offer it doesn't mean people aren't going to have to pay for that right. There's two big exceptions to this. Is that if you have just a traditional Medicare or you have an Advantage plan, you can, if you move out of your Advantage plan area in Oregon, for instance, you can then get and apply for a supplementary plan with no questions asked. Or if your Advantage plan is operating and it shuts down, like many of them are, you also have the right to switch over to a supplement without anybody asking you any questions. Okay, now next page. What are the supplemental plans to pick from? There's basically 10 of them plus 2 of them that have high deductible options. If you get Medicare before January 1st of 2020, there's 2 additional plans you can be offered, is C and the F plan. The F plan is very popular. It covers every last dollar. It's the highest cost plan. It covers all 6 of those gaps. After going on Medicare after the beginning of 2020, you have these A, B, D, G, K, L, M, and N. I'm only going to cover G and N because that's the popular ones. They're both great options. 70% of the people that get supplements get a G plan, 30% get N plans. Not many people get any of the others, so it's not even worth talking about. The difference between the F and the G plan for people that are after 2020 is that it fills 5 of the 6 gaps. There's nothing to fill all 6, leaving you with just one. It's the Part B deductible of $257 for 2025. That's the only payment you'd be making if you have a G plan. The N plan is just as good. It's about $30, $40 cheaper. It fills 4 of those 6 gaps, all the hospital gaps and the excess charges. It leaves you with the Part B deductible and the 15% excess doctor charges, if any. Plus, you'll be taking on a $20 copay to see doctors and $50 for emergency room fee, and that's waived if you're admitted. But it's a little cheaper plan, but it's a great plan. It's just almost as good as the G plan. You get to get it for a little bit cheaper. Next page. G plan in Oregon is about $150 a month. This is for a non-smoker at age 65. And I said before, men pay a little more than women. The price goes up every year. Well, the next page will show that. The N plan is $30 to $40 less. Both are great, probably much better than your employer plan ever was. If you get a G plan or an N plan, it doesn't matter who you buy it from. It's all the same. If you get a G, it doesn't matter which company in Oregon that's selling it. It's the same plan, same with an N. It just has different costs. And we'll show you on the next slide. You basically pick the company based upon the price and their historical stability of their rates. They've got various ways to base their rates on here, but most of them use attained age, raising the rate every year based on age. I looked at all the plans. I kind of found that the United supplement plans seem to be the best in price, both now and seemingly for future pricing. And of course, it's a strong company.
United Healthcare, right? Okay.
Yeah, AARP. Again, you'll have to add a D plan if you're going to get a supplement to be able to purchase drugs at a pharmacy and to avoid the penalty. You can always change back to an Advantage plan during the open enrollment period, which we're in right now. But to try to go the other way is going to be real hard. Of course, you can always go back to Medicare A and B only too. But why would you want to do that and leave yourself with all those gaps? But you can switch to Advantage plan, but if you go the other way, you're going to have to go through underwriting. Next slide, I just show the prices of these supplement plans, and I picked the G plan. I don't know if you can open it. I know it's small, but it's every company that's selling the G plan in Oregon. And I'll just say that the lowest cost plan is USAA, and this is at age 65. And I didn't really figure out whether this showed men and women or smoking or non-smoking. It just shows what I see here.
I think you have to be according to the ads I see on TV, you have to be a military veteran to qualify for USAA, I think.
Yeah, I think it's a pretty loose thing, like if you have a relative, but I'm just using an example of that.
Okay.
USAA was $143 on the low end. The highest was some company called GPM Health. For the exact same plan, you can see that they're charging $283 versus $143. They're not going to get the business. They don't want the business, it looks like, but it's the exact same G coverage, which is filling 5 of those 6 gaps. United, I just put they have a midpoint price of $152. At age 65. They also, you could see on here that they have a select plan at about $10, $15 less. It basically puts you into their hospital network. I wouldn't get it because the whole idea of having a supplement is to not have networks. And if you want to be going to a hospital that's not in their network for non-emergency purposes, you just want to use it for whatever reason, you won't want that plan. So I just don't highlight that much.
Right. I just have to mention something. We can't, as part of AII, we can't actually make formal recommendations, but it is very valuable that William is sharing the research that he's done on these plans. And it's good to know, I mean, the different same plans, different price points. But of course, as you mentioned, William, the networks maybe some are going to be better than others for this type of thing. So, but you've got to do your own research on that before you make a decision. So,
and remember, for all these plans, the supplemental G plans, there are no networks except in that little one called the Select Plan for United. You can go to any doctor, still have the same benefits. You don't have to have pre-authorizations, and that's why it's the quality option.
thank you for clarifying that.
Next page, I switch over now to the other option, which is replacing A and B totally with a Medicare Advantage Part C plan. And you'll still pay the $185 a month to Medicare, but you basically transferred the liability to a private insurance company that takes everything on. You're not dealing with Medicare at all anymore. You'll never even use the Medicare site. They won't talk to you anyway if you're on a private an Advantage plan. And so I'll try to go over to the aspects of these plans. These Advantage plans are very, very easy to get, no matter what age you are. And you'll never go through underwriting. You'll have an initial election period, which is a 7-month window that starts 3 months before you turn 65 and ends 3 months after. If you start Medicare later, you use the open enrollment period of October 15th to December 7th, which is what we're in now. In picking these plans, there's about 30 different plans by about 10 companies in this tri-county area. As I said, you still pay the $185 for every month for your Part B premium. Medicare transfers the entire liability to a private company. I've tried to figure out how much Medicare pays for this, but the figure I normally get is about $1,000 a month to take on this risk. So you can see, to get, pay $185 to get $1,000 plan is a good deal. You earned that right.
I want to point out that we realize that we're doing this research from an Oregon perspective on 30 plans in the Tri-County area. We realize we have some participants today that are not Oregonians, so it's going to be unique to your market. So you want to do that research.
But if you're in a big city, you're going to have pretty much the same choices. You'll probably have the same companies. They'll just have plans that are more geared to that area and networks that are geared to that area, but it's basically the same thing, especially if you're in a big city. You'll basically pay this if you go on an Advantage plan. The monthly payment for Part B will be taken from your Social Security payment, unless you hold off on Social Security, and then you pay it quarterly. You just arrange to pay it quarterly if you're just only on Medicare, paying Medicare, and you're not on Social Security yet. This enrollment period we're in now is the special enrollment period where you can change plans, as you can also from January 1st to February to March 31st. You can go from plan to plan, company to company, back to original Medicare, but with no supplement, because if you go back and get a supplement, you're going to have to go through underwriting. Next page, more on Advantage plans. They build these plans, and you see that all the time. They're built with a zero or a low premium, and co-pays and co-insurances for everything you do, except for usually your primary care visit. Everything is a pay-as-you-go type of plan. About half the people are on these Medicare Advantage plans, and then there's also some that have a drug plan with it, some that don't. If you have creditable drug coverage from other sources, you don't have to you can just get a Medicare Advantage plan with no drug coverage. These plans are made up of HMOs, HMO POSs, and PPO plans. All have networks of providers, and you have to stick with those networks. Some of the HMO POS plans and the PPO plans allow you to go out of network. The problem is that you're going to pay 40-50% if you go out of network. So is it really worth it? I haven't found that to be the case, but if you're on an Advantage plan, you want to go to Mayo Clinic, I guess you can if you're on a PPO plan, but you're going to be paying pretty much half of the bill.
One of our participants pointed out that you can go to Medicare, and I know you're going to mention this later too, William, but Medicare.gov, and that will you list your zip code area, and they will show you the plans that are in your area, and you'll get to that as well. You can also use an agent. Go ahead.
Yeah, you can use Medicare.gov to check the plans. You can also use it to check drug plans and put your drugs in there to find out especially if you have a supplement, so you can look at the different drug plans. The Advantage plans come with the plan embedded. So they'll usually your primary care physician is a zero copay on Advantage plans. Certain preventive services are free, like flu shots and things like that. But there will be, because you're now not on a supplement, but you're on an Advantage plan, you'll have to pay copays on specialist visits, hospitals, outpatient hospitals, detached ambulatory surgical centers, skilled nursing facilities, X-rays, advanced X-rays, outpatient rehab, physical therapy, emergency room, ambulance, urgent care. Everyone you'll have a copay on. And that's on the okay. And then there'll also be 20% co-insurances for durable medical equipment. This is on the medical side for chemo and Part B drugs, which are expensive drugs for cancer and for other things, and for the high-end therapeutic radiology, the high-end X-rays. There'll usually be a 20% copay on that with Advantage plans, and there's just no way around that. That's the only thing that protects you from that is your maximum out of pocket. And that's where I say here that for 2024, the maximum out of pocket is a maximum of $8,850 for an HMO. And for plans that let you go out of network, the max is $13,300. So you can add those two together if you go out of network. So the latter number covers both in and out of network. The average for Medicare Advantage plans is around $6,000, I see in Oregon. And then after that, you pay nothing, but you're paying up until you reach that on everything you do, except for your primary care visits. These plans are also sold, and you'll hear it all the time, with a bunch of extra benefits. They throw in some dental. These are limited benefits, I feel. Some vision, hearing, gym, telehealth, sometimes alternative care and over-the-counter benefits, and they throw in the routine physical that the supplement doesn't carry. Some people love these things.
Let me just interject something. One of the attendees on the call today mentioned that with the changes in Medicare for 2025, that the out-of-pocket number has been reduced to, so that's, I believe he said it's 3,500 down from that, and so from, I guess that's versus the 8,850 that you've got listed here. So
the maximum is 8,850, but they don't reduce that. Every company decides what they want. It's like with for next year, Providence has a $5,000 one. Pacific Health has one at 6,500. United has one at 4,500. So they decide how much the MOOP is, and it usually goes up, but it's not set at all. Some of these plans are built for, they're called SNPs, which they have they're specialized needs, like people that have cancer, diabetes and heart, they can gear the plans into special needs plans, but they're really just changing around some of the benefits to apply to those type of people. It isn't really a huge thing. There's also plans called give back plans that sometimes will pay you back your B premium of 185 or part of it, but they do that by taking away the extra benefits. So it's, again, probably not a good deal. If you get an Advantage plan, you can switch, special switch you can do to a supplement during the first year only. But again, it's after that first year is where you got to be careful. But you just can't switch on your own in Oregon. Like I said, the plans get their money from Medicare, and they actually get more money if the more things that you're diagnosed for, the more money they get. But it doesn't necessarily mean that they want to treat those things. It's just the way that they get their money. Next page is the negatives of Advantage plans. These plans they're annual and not portable. You must stay in the network. Um, like I said, some of the plans let you go out of network, but the cost will be considerably higher. These networks can change at any time. Um, and the drugs on the formulary can change, as can the tiering for those drugs, and the copays for those drugs can change anytime during the year. They'll let you know, but it's just any Advantage plan and any drug plan can be changed. Even the supplementary plans that where you buy a drug plan, that plan can change during the year. So you got to reevaluate your Advantage plan every year.
Wasn't part of the I may have been part of the Inflation Reduction Act too, where I think the Biden administration said they reduced the maximum for insulin for diabetes treatment. So that's
For
something that
certain
was separate legislation, but and that's independent of the companies that make other adjustments as you were talking about, right?
For some insulins, not all, but some, there's a $35 maximum in place per month. Um, and next year there'll be negotiated prices on 10 new drugs, 10, the first 10 drugs. But so these plans, they can be improved. They can decrease the plan every year. They can even shut it down, as have 15% been shut down this year. These plans usually have an embedded drug plan. They choose the plan unless you have drug coverage somewhere else that's creditable. You're going to get an embedded drug plan, and they're going to choose a plan. They're usually just kind of medium plans. Um, so this is where on Advantage plans it gets a little sticky. They require pre-authorizations on about 70% of the time for outpatient hospitals, your ambulatory surgical center, hospital stays, skilled nursing facilities, chemotherapy, your durable medical equipment, high cost X-rays, and the Part B drugs, and some lab services can all be subject to having to be pre-authorized. And doctors hate this, but that's what they have to go through on these Advantage plans, is to get permission. About 7.4% of the time, they are denied. You can appeal it, but of course that takes time and hassle. I looked it up, and it said about of the ones that were denied, about 10% were appealed. And they were fully or partially overturned 83% of the time. But again, only 10% were appealed, and it can take months. So in these co-insurance categories, you have high liabilities only protected by your maximum out-of-pocket figure. You may need referrals to specialists. I don't think that's a bad thing necessarily, but some of these plans, or you can see a specialist only through a referral from your primary care doctor. This MOOP happens every year. It resets in January. So whatever it is, that you'll have to start it all over again next year. One thing I noticed with these plans is a lot more auditing and paperwork than with a supplement. You're auditing what they do, what they're paying, the extra benefits that you're getting takes a lot of paperwork to get them. I find dealing with the customer service of these Advantage plans, most of the time it's overseas. There's people are very untrained, have high turnover. I just refuse to deal with them at all, and I just ask for I ask to be onshored so I can talk to somebody who is here. But even they're not very well trained, I find, on these Advantage plans. If you selected that Advantage plan and have it for more than 1 year, and then you say, I want to change to a supplement, that's where you'll face those 30 to 40 questions, and they'll want to know the drugs you're taking also. These questions are very, very hard to get through. Most people would be eliminated from it, especially as you get older. So it's an important election period decision you have to make at the beginning. All these perks are promised by these plans, generally they're very unused. I read a figure where only 5% of the people even use the gym benefit. These companies are notorious for slow pay, low pay, and no pay. This is why the providers do not like Advantage plans in general. Next page is, okay, which is best between these? Some of this is my own opinion, but I first wanted to say, I just found this interesting, is why are we buying insurance at all? Health insurance, because no one wants to pay retail for health insurance. All providers' charges are written down first. A doctor can charge $900, it can charge $1 million for a 5-minute visit, but he's not going to get that. With an Advantage plan, those rates are written down to a contracted rate, just like they always have with your private plans. With Medicare, they're written down to what they call a Medicare allowable rate. So if they charge $250, it'll be written down to, let's say, $100. And if he wants to charge 500, if he wants to charge $900, it gets written down to $150. And these reveal what is owed to the provider and are always discounted, sometimes heavily, and the balance is what you and the plan pays based upon the type of plan you have. But getting that right down is the first real benefit of insurance. Okay, moving along, next slide. Next 2 slides show what I've gone over already. And I've tried to do a side-by-side comparison of supplemental plans next to Advantage plans in all these categories. And I just thought that maybe you could just take some time and kind of compare them yourself instead of me repeating it. Just for instance, I said on supplemental plans, there's no networks to deal with. Medicare Advantage plans, you have to stay in networks. So maybe you can just kind of look at both sides and absorb. I tried to keep the same subject, but what one plan does versus what another plan does. Does that sound okay, Todd? Just kind of.
That's a good comparison. And let's see, you have phones, you might want to take a photo of this. It definitely makes sense. And one of the things, that William has pointed out more than one time in this presentation is, the Medicare Advantage plans, which, full disclosure, I'm on one of those, is less expensive because you're not paying a premium. Most of these will, like the United Healthcare plan, which is sold through AARP. I'm on the PPO #2. There's no fee. And you're paying a fee for the supplement plan. But one of the things you have to look at is, what about the future? What's going to be if you were to become seriously, you may get to this, but William, but you want to perhaps consider 5 years down the road. It'd be one thing if you could switch back and forth easily between a Medicare Advantage plan and a supplement plan. But as you pointed out, it can be difficult to qualify for a supplement plan. And what if you prefer that type of coverage 5 years from now? That can be an issue. So that's something to think about in comparison. So
Right. And the key differences on this list are, remember that the networks, they're very important. One has them, one doesn't. Like Todd said, you pay up front for a supplemental plan. Medicare plans are sold as, hey, no premium or low premium, but you're going to pay as you go for everything except for primary care visits. The pre-authorization thing I think is important. And that supplemental plans kind of win in that regard. Supplemental plans are just less work. They're just a better grade of coverage. But Medicare Advantage plans are not bad. They just require a lot more, you know, management.
As you point out, you're going to pay obviously a lot more for supplement plan than a Medicare Advantage plan, at least in terms of the cost of the premium. And again, the supplement plans, and it's not like an insurance policy where you're or the type of insurance you buy where you're locked in for one premium. For the supplement plans, I mean, for more than 1 year, the supplement plans, your premium will increase every year, correct? So.
Yeah, it'll go up and up and up. Even in that graph I showed you, that thing, the United plan. Remember, United sells both supplements and advantage plans, obviously. So, but on their supplement plans, by the time you're 85, they're showing prices now of like, I don't know, 300, 350. So it will go up. But again, it's still great insurance and it's cheaper than buying if you bought this plan on the open market, if you could. Medicare's paying a lot of this.
When you said 300, 350, was that a monthly
Yeah,
charge? Okay.
yeah.
All right. Okay.
Um, Again, the supplemental plan needs a Part D plan. Medicare Advantage is embedded. Uh, Obviously, supplemental plans don't have extra benefits. Medicare plans has those extra benefits, but they're kind of limited. Second page of this is the finishing of this side-by-side comparison. If you want to go to that, and what's important there is um, when you're with a supplement plan, which is basically just dealing with Medicare and their supplement company, doctors make the decisions. It's just not profit motivated, and that's one of the reasons why some of the people in government don't like these plans because, it's the doctors have too much control. With a Advantage plan, these plans are out to make money. That's why you have the pre-authorizations. Um, You don't, with a supplement plan, you don't really need much customer service. Um, um, Providers like supplements a lot more than Advantage plans. And you can switch the slide when you think, Todd, people have had a chance to see this comparison. Second page. Okay. This is kind of my take on all this is the best insurance. I think you should always look at a supplement as your first option because it's just the best insurance. Having A and B with a added supplement Medigap policy. It's just really good insurance, whether it's a G plan or an N plan, you're going to have a really easy life and not have to hassle any hassles with your claims and your care. If you can afford it, because it's going to be the $185, it's going to be $150 a month. That's at age 65. Plus, you're buying a drug plan that's an average price of about $40. So it's about $400 a month, all told. Whereas people on Advantage plan are only paying the $185, but they pay as they go. And then they throw in these extra benefits. So I'm sorry. With the supplement plan, you then have to buy your own gym, your own dental, your own vision, because it just doesn't have extra benefits. However, if you're a traveler or somebody who snowbirds someplace else, you're probably better off with a supplement policy because outside of emergency care, how are you going to get care if you're not in the network of an Advantage plan? It'd be better to be on a supplement. If you live in a rural area, there's not an Advantage plan network there, or it's very small or not worth joining. So you might be better off with a supplement.
It really varies. The networks vary in terms of the quality of the different plans, like like Moda or Humana are going to have different networks than United Healthcare will. So it's important to ask about those questions. One thing you have to ask, are my doctors in network, your existing doctors, before you ever get on a Medicare plan? Again, if it's a Medicare Advantage plan, you're going to want to ask those questions. Are the hospitals I normally use in network? Are the doctors I use in network? And
And
then
are your drugs on the formulary?
Yes, yes, that's right. Which is a, formulary for those who don't know that terminology. That's really the network for pharmaceuticals, right, William?
Yeah, it's a list of everything that they cover under whatever tier. Um, so if you want mostly everything covered up front, then you just go with a supplement G plan or N plan. It's also uh, better to go with a Medigap policy if you just don't want to deal with a lot of paperwork. Um, if you have chronic conditions, things that are costing a lot, like cancer, Part B drugs, you absolutely should be on a supplement plan because you won't have that 20% um, co-insurance that Advantage Plans pays that is only protected by the max amount of pocket figure. And
Are
if you,
are a supplement plan and a Medigap plan the same thing?
yes, exact same
Okay.
thing. If you don't want to deal with this pre-authorizations, which usually isn't a problem, but it can be a nightmare, you'd want to go with a supplement. Um, and Also with a supplement, you won't have to uh, reevaluate it every year for what you were saying, Todd, for doctors, your hospital network. Is it still in network? Are the docs in network? Are your drugs in network? What's the new copays? What's the changing of the maximum out of pocket figure? Um, so if you want maximum flexibility, um, you would go with a supplement. Why would you go with an Advantage plan? That's the next slide. And then we go on to the drug plans and finish up. Um, Basically, people on an Advantage plan should go if you have a tighter budget. Um, you want zero or low premiums and a few limited perks, and you find that interesting. If you're not a big traveler, you're able to stay in network. Companies like Regents and Aetna and United claim that they have these travel networks that you can use. I don't know a lot about that, but I just know if you're on an Advantage plan and you go on the road, it's okay if if you have urgent care or hospital care that's an emergency, then you can use it. But as far as using their travel networks, I don't have much experience with that. If you live in a big city, Advantage plans are a good option for you. I noticed in Coos Bay that there's only one Advantage plan sold down there. I can imagine the network being very small down there. So again, that's to me a rural community, and you'd probably be better off with a supplement so that you could come to Portland and get your care where you want. Um, if you don't mind the paperwork, Advantage plan is okay. Um, and if you don't want to deal with buying a separate drug plan, Advantage plans generally, unless you have your own drug plan from another source, um, Advantage plans are the better option. Next is Advantage plans are okay if you're generally healthy, but like Todd said, you got to consider the future. So I picked up this thing. I haven't written it down here, but it says I'm healthy now, but 95% of the people will get at least one of the following: cancer, diabetes, osteoporosis, heart disease, Alzheimer's, dementia, arthritis, stroke, incontinence, COPD, and other chronic conditions. 80% of people will get two of them. So that's the tough decision I find, is that you find, oh, I'm okay on an Advantage plan now, but what about later on? I want better coverage, and it's hard to make the switch. But that's your choice. You would also get an Advantage plan if you generally can stay in network and be satisfied with that. that, and you're okay with paying co-pays and co-insurances for everything, and you can live with that annual maximum out of pocket figure. Um, and but you'll have to realize you're going to have to probably need pre-authorizations, which in 2 years from now they have to give you a decision within 7 days in 2026. But if they turn it down, the appeal process can take forever. If you don't mind dealing with lousy customer service, then Advantage plans are fine. And of course, and then lastly, if you lose your guaranteed issue rights to change to a supplement once you've had the Advantage plan for over a year. I put a little side note in here for people that are looking at these things. You got to avoid peer pressure. You have the people that are kind of don't know a lot about Medicare and stuff like that. They'll say things to you that say, well, I don't have to pay a premium for my Advantage plan, or I get my gym free. Obviously, they're talking about Advantage plans, but that's not the whole picture. I'm trying to give you the whole picture here and the comparison between the two, but that's what you hear a lot from people, and they don't really understand the whole criteria. Okay. Now, just two more quick things. Part D plans is the next category. This is the plan that come with a Advantage plan automatically embedded. If it's a supplement, you buy it separately. They're offered by private companies. They're using Medicare guidelines, but they're basically privately offered. Once you have a drug plan, like on a supplement, you have during this open enrollment period, you can change to a different one. Again, if you don't sign up for a drug plan and don't have credible coverage somewhere else with your Medicare Advantage plan, where you just get an MA plan, you will face penalties for this as well as for Medicare B penalties. The supplemental plans that have drug plans, there's about a $40 average cost. They have to carry 2 drugs in every category and all drugs in 6 categories, including the categories of cancer and antidepressants and 4 others. The cool thing for next year is that there is no more donut hole. That was such a complicated thing to figure out, and it is now off next year. It's also what's called the coverage gap. Your drugs will just be your formulary, what they're covering, and they'll be assigned tiers 1 through 5, 1 being the cheapest, 5 being the most expensive, and these can get very expensive. They've also raised deductibles this year in most plans to the maximum of $590. But usually those apply to tiers 3 and above. Tiers 1 and 2 you don't have to burn through that deductible.
These are tiers for the different categories of drugs, right?
Right. If you have a drug like levothyroxine, Synthroid is the brand name, but they give you levothyroxine as the generic, it'll be assigned to tier 1 or 2. Very cheap. You don't get much insurance coverage for that because it's so cheap, but you'll probably have to pay $0 for it, and then they'll pay the pharmacy a few cents. But once you get into tiers 3 and above, especially tier 5, you're going to face higher tier copays, which is, for most plans, it's like $40 in tier 40 or $50 in tier 3, $100 in tier 4, or now I notice they're changing a lot to a co-insurance, which I don't like, but where you pay a particular percentage, usually about 25% of the negotiated cost of the drug, is the new change in drug plans for next year. But after you pay your deductible, the initial period starts. There is no coverage gap anymore. You just have initial period. It's a maximum of 25% in tiers 3 and 4, but your co-insurance can be less. Your co-pay can be just a dollar figure, like 40 or $50 in tier 3, or $100 in tier 4. But it can't be more than 25%. And what you're trying to burn through is to get to a $2,000 cap. and that's the new cap for covered drugs next year. It'll go up every year, but it starts at 2,000 next year. You're then in the catastrophic phase and you now pay nothing. And as Todd said before, there's a $35 cap on certain insulins. This $2,000 cap includes the deductible. It does not include any premiums that you paid for this for if you have a supplement and you're buying the drug plan. It's just your actual out-of-pocket costs. If you get hit with a $2,000 cost the first month because it's a tier 5 drug, they've instituted a new program called drug smoothing where you can smooth it out over the year. Only about, I don't know the exact figure, but maybe 10% of people will be subject to this cap. Nobody really knows yet, but most people are never even going to get close to it because most people are just taking tier 1 and 2 drugs, which are cheap. So the big change is the $2,000 cap. To look at your drug plans, use Medicare.gov to compare the drug plans. Why is there this big change this year? Why is it going to $590 copay in many of the plans, deductible in many of the plans? It's because of the $2,000 cap, new thing, nothing comes free. So because of that, and because Medicare will be paying only 20% in this catastrophic phase after the $2,000 amount. The plan is now going to have to pay 60%, and that's up from 20%. And that's why these plans have gone up in cost. That's why they've taken drugs off the plan. That's why they've raised the tier, put the drugs in higher tiers, and they've had a bit higher tier copays.
And
As I
it's
said,
also with the Inflation Reduction Act. I mean, some of these, because as you pointed out, some of the costs are capped for specific drugs. You know, the insulin is just one example. That makes it tougher for these companies to make as much money. So they may have to adjust deductibles and other things so that the insurance companies can still continue to make an acceptable return on selling these plans. And then some companies will opt to uh, just get out of the Medicare Advantage plan business. You know, I recall because I did some consulting with a local health insurance agency here that, you know, for not to pick on them, but Moda Health rolled out their Medicare Advantage plan in a big way a couple of years ago. Got some outside agents to sell them, and then now they say we're not going to offer Medicare Advantage plans after next year. So it's important to point that out and do some research and know which insurance companies. Sorry, I muted by example, so nobody heard what I said. But it's important to do your research with these insurance companies, see who's going to still be in the plan, still offer plans going forward. I used the example of Moda Healthcare, which rolled out their plan with a lot of publicity behind it, got agents to sell it a couple of years ago, and now they're announced, oh, we're not going to do Medicare Advantage plans going forward. So it is important to do that research. And
yeah,
so, yeah.
Moda just couldn't make a deal with Providence. They're a hospital provider, and so they just decided to get out of the market entirely. So people had to change. That's, you know, the whole plan blew up. So, um, okay,
William, I don't know if you're going to be talking about the agents themselves, because there are, I mentioned, you know, I've done some research with or some consulting with a local healthcare insurance agency. They happen to be, they have what's, you know, open architecture. You know, we use the investment business. I'm an investment guy, but they have a variety of, you know, there are plans, or there are health insurance agents out there that offer a variety of plans.
right,
Some offer every plan in the market, and others are what's called captive agents. They work for one specific company. So if you talk to them, you're only going to they're only probably going to recommend their insurance company that they're captive to, and or they're not going to talk about you to you about alternatives. And that's that you can still work with them if you know for sure you want that company plan. And it's also important to point out that these agents are very knowledgeable. I mean, William's offering this information from a consumer standpoint, point of view, which is very valuable. But there are agents that are very knowledgeable in the field as well that can offer you a lot of advice on these plans. And actually, it doesn't cost you anymore to use an insurance agent versus just going to Medicare yourself.
And
Because what
I'll
happens?
cover that on the next and
Okay, you will. Okay,
last
all right. Go
page.
ahead. Go ahead. Okay.
Okay, finishing up with drugs, they can add or subtract drugs all the time, change the tiers that they're in and the amounts that you pay in those tiers. Um, uh, Usually you have to make sure you go to your preferred pharmacies, especially in tiers 1 and 2. It's cheaper that way. Standalone plans that you get with your supplements had huge price increases this year, and we were affected by that. But there was a last minute bill by politicians that hid that fact. They wanted to do this before the election. So they basically kind of subsidized these drug providers, and where the price wouldn't go up more than $35 a month. But I don't know where they got the money from, but it cost the government billions to do this. Advantage plans didn't get this subsidy for their drug plans. Hence, that's why so many of these plans, including mine, had these big changes for this year with high deductible, higher co-pays, co-insurance for tiers 3 and 4 in my plan, for instance, and formularies that changed, which they never really tell you how the formulary changes. They just tell you whether your drugs are going to be on the plan next year, but you can't, otherwise you have to look at their list of 3,000 drugs to figure that out. Sometimes in tiers 3 and 4, I'll consider using GoodRx because I can beat the prices of the insurance companies, especially during the deductible phase.
And what is good RX, if you can explain that?
It's just coupons. You see their commercials all the time, and you just get their website or their app. I wouldn't use the GoodRx card, but you go on the app or the website, and you'll look for the coupons, and many times, probably 60% of the time, in tiers 3 and 4, you can get better prices. Whether you can use those receipts to apply against your deductible and towards your cap, I don't know. I've been told both ways. If I did it, I would keep them, and I would try to get them applied to my deductible. But the jury's out on that.
Well, and there are other companies too that offer those kind of discount drug prices. But William's done a lot of research on this, and I agree with him. I think GoodRx is we can't recommend anything formally, but they are a pretty good vendor, something you probably want to look at as a discount drug provider, and you can use those whether or not you have other pharmaceutical coverage. I,
Right.
I actually had a situation where, and I think it was on Medicare, but there was the good RX price was lower than my discounted drug price. It's always good to compare those. If you're paying a couple of bucks or something, or next to nothing for the formulary drugs, well, there's no exercise to do. But in a case where you might be paying more for a specific drug, and it's a higher tier level, it's worth doing the exercise to say what is less? Can I get the lowest price going through my insurance plan, or should I look at the good RX as comparison, as an
It's
example?
like I bought a drug that was on my plan as a tier 4, and since I had a deductible to burn through, I'd had to pay the $110 for it before, as I was burning through the deductible to earn the $100 cost. But I looked it up on GoodRx and found it for like $26. So it's a good option to try. There's other companies besides GoodRx, but I just find that they just have the most widespread coverage of these pharmacy benefit managers that other companies don't have. Finally,
Okay.
is for people that have, and I mentioned this before, not everybody has to get a drug plan. If you have VA drug coverage or something called TRICARE for Life, which is after you retire from the federal, let's see, I'm not sure what TRICARE is. I think that's military veterans that had a career in the military, or FEHB if you had a career in the federal government. You can continue on those drug plans and just get a Medicare Advantage plan only without a drug plan, or you can get a supplement and not get another attached drug plan. And a lot of people do that, and it's a good option for them.
Well, I guess I don't know much about it, but Mark Cuban has this plan. For those of you who know Mark Cuban, some of them may know Shark Tank, but he's a billionaire and made a lot of money in tech. And he's got a plan that he's, I think, administering through Amazon, where you can check prices there too. But I don't know much about it. Do you know anything more than that, William?
Yeah, Amazon has their own kind of pharmacy that they started with a company called PillPack, and you can buy things just like you would anything else on Amazon. I don't find their prices any better than GoodRx's. With Mark Cuban's company, what he's done really is just take a lot of the lower cost drugs and he's like sourcing them himself, adding a small margin, adding a shipping fee. Most of those drugs are things you can get on your drug plan for cheap because they're going to be in tiers 1 and 2. These are the mass market heart drugs and, the levothyroxines of the world, and it's just another source, but, it's good to know and check all these sources, I guess. Lastly, last page. Thank you for listening to all this. The little one-page thing on brokers. I think, you can go it alone. My recommendation is that there's just too much to know. I mean, even as much as I've studied this area, there's just, I couldn't answer that one question one of the people answered. It's just a really tough area, and it's changing all the time. And like Todd said, these brokers deal with it. A good broker deals with it every day. And they can answer these little niche questions. It doesn't cost you, like with any insurance, mostly it doesn't cost you any more to use a broker. The insurance company pays the broker, you pay nothing. They can't recommend, just like Todd said, you can't recommend things, but they can give you the options, just like I'm trying to give you the options here. There's 4 types of brokers. The first ones are those ones that call you up on the phone. I just got one yesterday. And legally, they're not supposed to even be calling you, but they call you up and they're from some call center and they're just spamming you. Avoid those like the plague, just to hang up on those. The other one are the captured brokers. These are small brokers that really only sell 1 or 2 types of insurance. Like I've seen them, Regents ones for that sell just that plan. Kind of would ignore those too because they just don't offer enough mix of products to go with. Third one is agents that work for the insurance company. That's okay if you know what you want to buy. It's just kind of sometimes easier. That's what I do. I just call the insurance agent, the company itself, and deal with one of their in-house agents because I know what I want. But for most people, it's using independent brokers, just like all insurance. They represent all or most companies. They can be local, they can be national. I find in this area that there's a lot of shenanigans going on with some brokers. They basically still sell instead of helping you. They're in for the fast commission. An Advantage plan to them is a quick, easy sale for them. They work on volume. Brokers make twice as much with Advantage plans, and they get a residual forever. With supplements, they make half as much, and the residuals only go for 6 years. So you can see the incentive for them to sell you an Advantage plan and sell you on the no premium and sell you on the extra benefits. But That's how it works. So I've just listed three different sources for independent brokers. One is Sheba, which is an Oregon group of volunteers. Um, at that phone number, option two, that you can get meetings with Sheba counselors. These are trained people that can help you. They're not brokers, but it's just an information source. They give great advice. You just have to make an appointment to go in or get an appointment with somebody. Second one is a broker um, list by Sheba, that where they have a vetted list of brokers under that. Um, I know I had to write it all out there. That shows you brokers they trust that will give you good representation. The final one is a national one. You probably maybe heard of this guy. It's MedicareSchool.com. His name's Marvin Music. He's got a national company where he sells most of the plans, not all, but most of the plans. That's his 800 number. He's in Kansas, one of the best. And he has great school where he teaches the stuff I've been talking about, and he's really good at it. I would trust this guy implicitly. That's basically it. Every year with an Advantage plan, you'll get an annual notice of change where you'll have to look at, you'll like a supplement, you'll have to look at your docs, the hospitals, drugs, the plan changes, and um, and the formulary changes for the drugs. But that's pretty much all I have.
William, we do have a few more questions. Some of these are actually comments of attendees at the meeting sharing some information. So I'm going to go through those. And yes, somebody did clarify on the USAA. That's for military or police or firemen only. That's not general available for any kind of insurance, including Medicare supplement plans, unless you qualify in that area. Someone else pointed out the Mayo Clinic does not accept any Medicare Advantage plans. So if you're fortunate enough to get into the Mayo plan, I know they've got a clinic down in Arizona, by the way, in addition to, I believe, in the Midwest. So the Somebody also clarified they talked about the donut hole is gone for 2025 out of pocket is $2,000 apparently. Um, the also Someone else pointed out they'd had good luck themselves with Good RX, excuse me, which allowed them to shop around for the best price between CVS, Walgreens, Walmart. It's a nice app. I've used it myself, as I mentioned, and I can't speak for the other ones. It's the only one I've used, but it is easy to do a comparison between the different plans. So I was literally in line at a pharmacy saying, man, that's a lot of money. And I pulled up out the Good RX app and looked and saw, well, it's less expensive at Fred Meyer in that particular example. So I went over there and got it instead. And also the Also someone else clarified with thanks to Karen coming here for this Mayo clinic in Arizona does not accept many plans. So it's very important to point out again, whatever clinic you're talking about going to, if they will accept your plan. And again, if you're sticking with regular Medicare, with an A and B supplement, or without, you do want to check to see if your particular clinic is accepting more Medicare patients. I had a situation where my doctor left one clinic and went to another clinic. And after taking some time off because she was a caregiver for one of her parents, and she contacted me. I ended up staying with the clinic that she left, but be that as it may, she mentioned in the conversation when she called me that she had trouble finding another clinic to go to that would accept Medicare. So they were, full up and weren't taking any more patients. And so she had to shop some of them, and she finally found one that she did migrate to that does take additional Medicare. And I think it even varies because I did call that clinic to do some due diligence. Some of the doctors take some plans, some don't take others, some take others. and some take Medicare, some don't. So even if
Was
you're
this
talking about going to one clinic, it's not necessarily true that all of the providers at those clinics have the same rules or accept the same plans. You
was
have to
that
ask about those specific doctors. Go ahead.
was that Portland Clinic?
It was not. No, it
Yeah.
was not. It was a clinic in Hillsborough.
Okay.
Um, I just found out, by the way, it was in the newspaper yesterday that the Portland clinic is closing their downtown Portland location, predominantly due to crime issues. They have,
Right.
yeah,
And they also are a clinic, like you were talking about, that generally doesn't want to take um, they'll take some advantage plans, I think, but they don't generally want to take Medicare for your private PCP, your private doctor, but they'll take it for specialists, is what I found.
yeah. So it varies a lot. So it pays again to do your due diligence and ask a lot of questions. I know we've gone over our normal
Just
hour and a half, 90 minutes, but it was with good material today. Really want and appreciate, want to thank
just
William again for all the research he put into this and for his presentation today. I also want to mention John Wong, our reliable webmaster who helped us organize all the meetings, including this one, and was on this one today as well. And finally, I want to thank all of you who have attended and hung in there for most of the presentation with us today. And we'll be in touch on our future meetings that we'll be having. Normally, they're monthly, but we're going to assess that for the holidays. And we'll let you know if we're going to have a December meeting and what the topic will be for the AI National Income and Cash Flow SIG group. Thank you very much for attending today, and want to take this opportunity to wish everyone happy Thanksgiving and happy holidays as well.